All right, let's get right into this explainer. Today, we're breaking down the precise diagnostics and documentation for two of the absolute most critical metabolic emergencies you're going to encounter: diabetic ketoacidosis, DKA, and hyperosmolar hyperglycemic state, or HHS. Whether you're on the floor directly managing patient care, or you're on the back end ensuring accurate clinical documentation, understanding the razor-sharp distinctions between these two is, well, it's absolutely paramount. So, let's dive in.
So here's our roadmap for today. We'll start with the metabolic crises explained, then move into the clinical contrast between DKA and HHS, hit the ICU management protocols, and finally wrap up with ICD-10 coding precision.
Section 1. Metabolic Crises Explained.
Now, looking at DKA, you can really see how the underlying physiology maps out. We're talking about an absolute insulin deficiency, usually in type 1 diabetes, which basically creates a massive metabolic roadblock. Glucose literally cannot enter the cells. So starving for energy, the body is forced to drastically shift gears and break down fat instead. And it's that rapid fat breakdown that causes the dangerous accumulation of acidic ketone bodies. It essentially turns the blood into this highly toxic, acidic environment.
Contrast that with HHS, which we typically see in type 2 diabetes. Here, you've got what we call a relative insulin deficiency. There's just enough insulin floating around to prevent that massive fat breakdown, which is exactly why you'll see minimal ketone production. But hey, don't let the lack of acid fool you. This state triggers severe, totally unchecked hyperglycemia. That causes massive osmotic diuresis, meaning the kidneys are just flushing out huge amounts of water. The end result? Profound, literal life-threatening dehydration.
Moving on to Section 2, DKA versus HHS, clinical contrast. I highly recommend taking a mental snapshot of these clinical thresholds. Notice how DKA strikes super rapidly. We're talking within hours. And because of those ketones we just talked about, it causes severe metabolic acidosis, where the pH drops right under 7.3. On the flip side, HHS builds a lot more gradually, sometimes over days or even weeks. And look closely at that osmolality metric at the bottom. This right here is the defining feature of HHS, an extremely elevated osmolality pushing over 320 milliosmoles per kilogram. That's the direct physiological result of all that severe dehydration building up over time.
So the absolutely crucial point to anchor in your memory for HHS is the severe hyperglycemia threshold. In DKA, blood glucose usually hovers somewhere between 250 and 600 milligrams per deciliter. But in HHS, blood glucose often surges way past 600. When you see a number that high, it's a massive red flag that you're dealing with a severe hyperosmolar crisis.
And if you want to understand exactly why rapid triage is so critical, just look at the severity data. DKA is highly dangerous, for sure. You'll see classic signs like fruity breath and Kussmaul breathing, and it has a mortality rate of roughly 2 to 5%. But HHS, it actually carries a significantly higher mortality risk of 10 to 20%. Why? Because it comes on so gradually. Patients often just don't seek help until they are already in a state of extreme cardiovascular compromise, severe confusion, or honestly, even a coma.
All right, Section 3, ICU Management Protocols.
Once you've got the diagnosis, the immediate life-saving protocol in the ICU demands strict adherence to 4 key steps. Step 1, large-bore IV access for really aggressive fluid resuscitation. You've got to restore that intravascular volume immediately. Then step 2 is insulin therapy to start lowering that blood glucose and shut down the ketone production. Step 3 is strict electrolyte management. Potassium in particular can shift incredibly dangerously during insulin therapy, so continuous monitoring is a non-negotiable. And finally, step 4, identify and treat the precipitating factor. Was it an infection, an MI, maybe missed medications? If you don't treat the root cause, the whole crisis is just going to loop right back.
Let's wrap things up with Section 4. ICD-10 coding precision.
Precision is literally everything when we move to documentation. Your first step is selecting the correct foundational block, E10 for type 1 diabetes or E11 for type 2. Then you've got to look at those final digits. You have to append the correct modifier to indicate the patient's neurological status. For instance, E10.10 is type 1 DKA without a coma, whereas E10.11 explicitly captures that the patient presented with a coma. That single little digit, it completely changes the severity profile of the entire medical record.
Now for HHS, avoiding coding pitfalls requires absolutely crystal clear provider documentation.
The clinical notes must specify the diabetes type, but crucially, and this is a big one, the physician must explicitly document the hyperosmolarity. A coder cannot just assume it from a high glucose lab value. You also need explicit notes on the presence or absence of a coma, the exact glucose levels, and whatever underlying event, like a severe infection or maybe a stroke, actually precipitated the crisis. Ambiguous documentation here, it leads straight to rejected claims and completely skewed quality reporting.
And that brings us to the end of this explainer. By mastering these razor-sharp clinical thresholds, from the low pH of DKA to the massive osmolality spikes of HHS, and then translating them into highly accurate ICD-10 codes, you're doing more than just paperwork. You're ensuring both patient survival and systemic integrity. You are the bridge between the ICU bed and the healthcare data system. But it does leave you wondering, as AI begins to automate coding straight from clinical notes, will these rigid ICD-10 distinctions remain entirely in the hands of physicians, or will algorithms soon be making the ultimate call on a patient's coma status? Something to think about. Keep analyzing, keep asking questions, and decode healthcare with Harshal.